What if losing weight wasn't simply about eating less? What if a tiny hormone released by your intestine could tell your brain you're full, slow your stomach, improve blood sugar, and even reduce your desire to eat? That might sound like science fiction, but it's exactly the principle behind one of the biggest breakthroughs in modern medicine: glucagon like peptide 1, or GLP-1 receptor agonists. Originally developed to treat type 2 diabetes, these medications have transformed obesity treatment by producing significant weight loss while also improving overall metabolic health. But perhaps the most fascinating effect reported by many patients isn't simply the weight they lose, it's that they stop constantly thinking about food. The cravings become weaker, meals become smaller, and the constant mental chatter about eating, often called food noise, begins to fade. So, how can a single medication produce such remarkable changes? To answer that question, we first need to understand the natural hormone these drugs are designed to mimic. The story actually began more than 2 decades ago. In 2005, the first GLP-1 receptor agonist, exenatide, marketed as Byetta, was approved for treating type 2 diabetes. Doctors expected better blood sugar control. What they didn't expect was that many patients also began losing weight. Even more surprisingly, patients repeatedly described the same experience. Food simply didn't seem as important anymore. Researchers quickly realized they weren't just treating diabetes. They had discovered an entirely new approach to treating obesity. Today, newer medications such as semaglutide, marketed as Ozempic and Wegovy, and tirzepatide, sold as Mounjaro and Zepbound, are changing the way obesity is managed around the world. But despite their impressive results, these medications aren't performing magic. They're simply enhancing one of the body's own biological systems. That system begins inside your intestine. Every time you eat, specialized cells called L cells, located mainly in the small intestine, detect the arrival of nutrients and release a hormone called glucagon-like peptide 1, or GLP-1. Think of GLP-1 as the body's after-meal messenger. As soon as it's released, it begins delivering instructions throughout the body. Its first stop is the pancreas. Here, GLP-1 tells pancreatic beta cells to release insulin, but there's an important detail. It does so only when blood glucose levels are elevated. This glucose-dependent action allows blood sugar to fall after meals while minimizing the risk of hypoglycemia. At the same time, GLP-1 suppresses another pancreatic hormone called glucagon. Normally, glucagon tells the liver to release stored glucose into the bloodstream. After eating, however, the body doesn't need additional glucose. By reducing glucagon secretion, GLP-1 prevents unnecessary glucose release from the liver and helps maintain stable blood sugar levels. Its next destination is the stomach. Here, GLP-1 slows gastric emptying, meaning food leaves the stomach more slowly. As food remains in the stomach longer, the feeling of fullness also lasts longer. This naturally reduces the desire to eat another meal soon after the first. Finally, GLP-1 reaches the brain. There, it activates appetite-regulating centers that signal the body has received enough food. Hunger gradually declines, while feelings of satiety increase. Together, these coordinated actions help regulate blood sugar, digestion, and appetite after every meal. It's an elegant biological system, but it has one major limitation. Natural GLP-1 doesn't last very long. Almost immediately after entering the bloodstream, it's broken down by an enzyme called dipeptidyl peptidase 4, or DPP-4. Within just 1 to 2 minutes, most of the hormone has disappeared. Scientists looked at this limitation and asked a simple question: what if we could create a version of GLP-1 that DPP-4 couldn't destroy? That question led to the development of GLP-1 receptor agonists. These medications are engineered to resist DPP-4 degradation while still activating the same GLP-1 receptors throughout the body. Instead of working for only a few minutes, they continue acting for hours, days, or even an entire week, depending on the medication. But extending the life of GLP-1 solved only one problem. It still didn't explain the remarkable weight loss these medications produce. The real story begins when they reach the brain. One of their first destinations is the hypothalamus, often described as the brain's appetite control center. This region constantly monitors the body's energy stores and decides whether we feel hungry or full. When GLP-1 receptor agonists activate receptors within the hypothalamus, hunger signals become weaker, while satiety signals become stronger. People naturally feel satisfied after eating much smaller meals. Another important target is the brainstem, which receives information from the digestive system through pathways such as the vagus nerve. Here, GLP-1 receptor agonists amplify the sensation of fullness, allowing satiety to last much longer after a meal. But perhaps their most fascinating effect involves the brain's reward pathways. But appetite regulation isn't the only way GLP-1 receptor agonists influence eating behavior. They also act on the brain's dopamine-mediated reward pathways, particularly within the mesolimbic reward system, which determines how pleasurable and rewarding food feels. Under normal circumstances, highly palatable foods rich in sugar and fat stimulate dopamine release, reinforcing eating behavior and encouraging us to seek those foods again, even when our energy needs have already been met. GLP-1 receptor agonists dampen this dopamine-driven reward signaling. As a result, highly rewarding foods become less appealing, cravings become less intense, and the urge to snack gradually diminishes. This is why many patients describe a reduction in food noise. The constant mental preoccupation with food begins to fade. Rather than relying on willpower to resist cravings, they simply experience less desire to eat. So far, we've explored how GLP-1 receptor agonists work. But understanding the mechanism is only part of the story. The next question is, what do these physiological changes actually achieve in patients? The answer explains why GLP-1 receptor agonists have transformed the treatment of obesity. The most obvious clinical effect is significant weight loss, because these medications reduce hunger, prolong fullness, and quiet the brain's reward response to food. People naturally consume fewer calories without feeling like they are constantly fighting their appetite. Unlike many older weight loss medications, GLP-1 receptor agonists work by restoring the body's own appetite-regulating pathways rather than forcing the body into weight loss. The benefits, however, extend well beyond the number seen on a weighing scale. Patients experience better blood glucose control, lower HbA1c levels, improved insulin sensitivity, and a reduced risk of persistent hyperglycemia. Many also develop healthier lipid profiles, including reductions in triglycerides and LDL cholesterol, along with decreased fat accumulation within the liver. Several large clinical trials have also demonstrated cardiovascular benefits, with some GLP-1 receptor agonists reducing the risk of major cardiovascular events in high-risk individuals. Taken together, these outcomes have changed the way clinicians think about obesity. Today, obesity is increasingly recognized as a chronic metabolic disease that can be treated by targeting its underlying physiological pathways. The remarkable clinical success of GLP-1 receptor agonists has transformed not only the management of obesity, but also the direction of pharmaceutical research. Rather than asking whether GLP-1 therapy works, researchers are now focused on an even bigger challenge. How can these therapies be made even more effective? Current research is shifting from single hormone therapies toward multi-hormone approaches that simultaneously target several metabolic pathways. Investigational agents such as retatrutide, which combines GLP-1, GIP, and glucagon receptor agonism, and amycretin, which combines GLP-1 with amylin receptor activity, represent the next generation of obesity pharmacotherapy. The future of obesity medicine lies in combination therapies, precision medicine, and personalized metabolic treatment, aiming to achieve greater weight loss, better preservation of lean body mass, fewer adverse effects, and improved long-term outcomes. Like every powerful medicine, however, GLP-1 receptor agonists are associated with adverse effects. Fortunately, most are mild and occur primarily during the first few weeks of treatment or after increasing the dose. The most common adverse effects include nausea, vomiting, diarrhea, constipation, abdominal discomfort, bloating, headache, fatigue, reduced appetite, and injection site reactions. For most patients, these symptoms gradually improve as the body adapts to treatment. Long-term considerations are equally important. Because weight loss can include lean body mass as well as fat, some patients experience muscle loss. For this reason, adequate protein intake and regular resistance exercise are strongly recommended. Rapid weight loss may also increase the risk of gallstones and gallbladder disease. Although uncommon, pancreatitis remains a recognized potential complication, and these medications are generally avoided in patients with a previous history of pancreatitis. In some individuals, gastric emptying slows so much that it progresses to gastroparesis, resulting in persistent nausea, vomiting, and delayed stomach emptying. Another important precaution involves the boxed warning for thyroid C-cell tumors, observed in rodent studies. For this reason, GLP-1 receptor agonists should not be used in individuals with a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2, also known as MEN2. Long-term appetite suppression may also contribute to nutritional deficiencies if dietary intake becomes inadequate. Some regulatory agencies have investigated reports of mood changes and suicidal ideation, although current evidence has not established a definite causal relationship. Another important point is that these medications treat obesity. They do not cure it. If treatment is stopped without long-term lifestyle modification, many patients regain a significant proportion of the weight they lost because the underlying biological drivers of obesity return. Although current evidence supports their short and medium-term safety, data beyond 10 to 15 years are still limited. In the future, GLP-1 therapies are expected to include improved oral formulations, personalized treatment strategies, and expanded applications in conditions such as metabolic dysfunction-associated fatty liver disease, cardiovascular disease, chronic kidney disease, and neurodegenerative disorders. These advances suggest that GLP-1 receptor agonists represent not the final chapter of obesity pharmacotherapy, but the beginning of an entirely new era in metabolic medicine. So, what is the key message from all of this? GLP-1 receptor agonists have fundamentally changed our understanding of obesity. Rather than viewing obesity simply as a failure of willpower, modern medicine now recognizes it as a complex metabolic disease that can be treated by modifying the body's own physiological signaling pathways. Before we conclude, it's important to remember that GLP-1 receptor agonists are prescription medications, not lifestyle products or quick-fix weight loss solutions. While they have transformed the treatment of obesity and type 2 diabetes, they are not suitable for everyone. Like all medications, they have potential side effects, contraindications, and require careful patient selection, dose titration, and ongoing medical supervision. Whether these medications are appropriate depends on an individual's medical history, underlying health conditions, and treatment goals. That decision should always be made in consultation with a qualified healthcare professional. Okay, friends. Thank you for watching, and I'll see you in the next video.